Ladies and gentlemen, thank you for meeting giving me opportunity to show our experience in robotic pancreaticoduodenectomy and visit this wonderful city. Our division is located under Beijing and belong Chinese PLA General Hospital. We have no disclosure. The main reason for surgical plan for pancreatic lesion depends on the location and the tumor nature, the corrosivity of pancreatic juice, and the vascular surrounding anatomy considered as the main reason for severe complications. Since in 1994, first case of laparoscopic PD has been reported. It takes a long time for us to accept it. In other hand, robotic PD was reported in 2003. This data shows the HPB surgery take 9% total robotic surgery in China. Thanks to the images in colorimetrics genes and the improvement of the understanding of minimally-invasive surgery, more and more patients accept this approach, and we still performed robotic surgery from 2011. Until now, our team successfully performed more than 1,600 robotic pancreatic surgery, and here is a configuration of them. The robotic system offers clear, more stable, and majorly fair vision and flexible and feasible movement than conventional surgery. After review of stats about PD, we do trust the evidence. Robotic PD always been thought expressive fee was low economic efficiency. We used to take respective study to compare this two approach, and all data show no difference in projective outcome and a little bit high conversion rate in laparoscopic group. It found that the type of minimally invasive approach was laparoscopic or robotic was not associated with overall complications. The predict of sitting die overall complication were high body mass index, vascular resection, and long operative time. Robotic pancreaticoduodenectomy was associated with a similar 13 days of complication rate to laparoscopic pancreaticoduodenectomy. How about a long time? This was respective staff used the national council debated between 2010 and 2030. It compared the penetrative pathological and many times oncological outcome become the RPD and LPD. Result, this was 1,623 MIPD cases was 19% was LPD and 10% were RPD. RPDs was more likely to be performed under academic century compared to IPD and a higher volume. This was the difference in the median number of experimental lymph nodes by gene status and carcinoma between IPD and RPD. The 1 and 3 years overall survival rate were 7.4 and 13.1% for IPD and 17.1 and 13.3% for RPD. This shows that in this national chart for patient IPD and RPD were essentially was equanimous operative, pathological, and meditamus oncological outcome. We don't really have many tips on who you are, but the time is limited, so just take a shortly. Train just the beginning and the complete training center only shows that how to use it, but never tell you how to deal with individual. Very important things we learn from our patients are also first burning your Mainland. You cannot just copy the operation from open. You need to try to fix the problem and go some new way. Resectables assessment should be explained as SMV and SMA in Y shape. L and R means left side and right side of SMV to find a vertical area for desiccation and digestive reconstruction. This R pulse was for PD constriction. And air pulse was minimal for the reconstruction such as GS. Okay. Oh.
You're going. Yeah.
Oh, okay. This video is 30 and 1 pancreaticoduodenectomy technique key points: pancreaticoduodenectomy transformation and desensitization and avoid aversion. 3 it means 2 you substitute, and 1 first is start. And 1 continue to substitute, sometimes infiltration back doors and vesicle. Suggest about robotic pancreas surgery if you want just the robotic. Changes approach in robotic way. Finally, don't be afraid of disadvantage because technical skills step forward. Thank you for your attention.